Yeah, so we're going to talk a little bit about perioperative risk assessment and see if I can advance this here. So this is the, just for this, because it's early in the year, I like to review the history a little bit. This is the quintessential perioperative risk stratification paper. It was the original paper by Dr. Lee Goldman. If you can see the names, may not be easy to see. But anyway, this was from the Mass General a long time ago. But it was an attempt by a bunch of residents actually at the Mass General to kind of get a better handle. They were asked all the time to see people preoperatively and assess their risk. And there were some studies years ago that told us ways to do that, but they decided to take their own look at it. And this was the Goldman paper on the multifactorial risk index. And it was really a classic paper. So I show that for its historical significance. There's many updates since that time, but that was the original in the New England Journal of Medicine, 1977. This is the latest. What's that?
Perry, it's worth saying that was based on physical exams done by general surgical residents, which is
right.
Definitely.
It was an incredible effort, though, because everybody, I think all the investigators were residents at the time, and they were clever. But you're absolutely right; it's highly suspect. But at any rate, gave us some ideas and got us started on the road. This is actually, I'm showing this next. We're going to go through the history of this a little bit, but this is the paper that the guidelines that the U.S. still goes on. They're 2014. You'll see the world has kind of passed us by a little bit. I'll show you, but our guidelines, the latest from the ACC/AHA official guidelines, are 2014 by Lee Fleischer et al. And we're going to talk about them a little bit because this is the gold standard still in America. So this is what came out of that paper, and I'm going to blow it up on the next slide. This is kind of what everybody talked about this morning, and where we got those ideas from is from these guidelines. So if you look at the upper left here, I don't know if my pointer shows, but that the patient is scheduled for surgery. That's the start. So then you get the call, patient needs surgery, and you're going to assess them. So the first question we always ask is it an emergency operation or not? And frequently the operations are emergent. A lot of times they need a craniotomy because they've had a subdural hematoma, needs to be evacuated. We had a question of that yesterday on the consult service. So, if it's an emergency operation, there's no time for stress testing. It's ridiculous. So then you proceed to the surgery. And of course, risk may be high, but it doesn't matter. You have to go forward if it's a life-saving surgery. But let's say it's not an emergency operation. Then you go to step 2. Well, is it an acute coronary syndrome? Is the patient actively having chest pain? Are they in trouble today from a cardiac point of view? And the answer is yes. Then you treat according to an acute coronary syndrome. So you do whatever you have to do for that. Excuse me. But let's say that's not an acute coronary syndrome. So like most of the patients, like the one today, then you have the time. If it's not an ACS and it's not an emergency operation, then step 3 is you assess their risk based on clinical and surgical risk predictors. So we'll talk about that in great depth in the subsequent slides. So if you determine that they're low risk because they're not diabetic, they don't have hypertension, they never had a stroke, not like this patient, and their risk is assessed to be less than 1%, then no further testing is indicated. You should go further. You should proceed right to surgery. No, in fact, additional testing is contraindicated. That's why that box is red. So if they're low risk, they go to surgery. If you deem them to be high risk, means above 1%, then you're up to the part where you have to think about functional classification. So that's where Dr. Mazzarelli mentioned the METs. If somebody can do more than 4 METs of activity, that's good. So if you can do more than 4, and if you can do a lot more than 4, let's say 4 to 10, you might not need to do any further testing. That's a 2B recommendation. But if you can do more than 10 METs, stop there. There's no reason for further testing, and then you proceed to surgery. But let's say, so if you're above 4, you're pretty much in the category go to surgery. Let's say you're not above 4, like our patient, poor or perhaps unknown functional capacity because the patient's in a coma and can't answer your questions. Then will further testing impact what you're doing? And this is the important part down here is if I do this pharmacologic nuclear stress test, am I going to act on it or not? If the answer is, well, I'm never going to cath this person, even if I know they have ischemia, then you probably don't want to go down that road, although sometimes you want to tell the team they're high risk or low risk, but sometimes you don't even want to know because you're going to open up a whole can of worms, and the surgery is not that high risk of surgery, let's say like an AV fistula. So I think Dr. Ginsburg is saying, does this patient even need anything? And the answer is, in some people's judgment, no, because they might say, we're not trying to do intra-abdominal surgery here. We're just trying to create an AV fistula, maybe, or do something like a breast biopsy. You certainly wouldn't put them through a stress test for that. But let's say, so if you wouldn't do anything, then you go right to surgery. If you're going to do the pharmacologic stress test, then that green box on the lower right says coronary revascularization is indicated as per the practice guidelines. So whatever you would do ordinarily, that's what you should do then. Let's move on. We'll come back to that. We're closing in on this. So this is a big long table that I blew up here to show you, well, what about medical management? What do we do, and what about revascularization? And so we're going to assess risk, low, medium, or high, but we also want to tell them, well, what to do. So this table informs us. So revascularization before non-cardiac surgery is recommended according to clinical practice guidelines. So if this person had left main disease, you would revascularize them. That's a class 1 indication because you would do it anyway. So why would you not do it now? So once you go down that road and you find the left main, then you have to deal with the left main. Now, you don't want to do revascularization just because you're doing it. There has to be a reason. So if there's a clinical practice guideline that says to revascularize, then you should. If you see, a 60% obtuse marginal lesion, you definitely don't want to touch that because you wouldn't ordinarily touch that. You leave that alone. That's a class 3. Don't do harm. Now, this is important here. Non-cardiac surgery should be delayed after PCI. So if somebody's had a PCI, then we have to delay 14 days after balloon angioplasty, 30 days after bare metal stent, or 1 year after a drug-eluting stent. And that's class 1 indication from these guidelines. So keep that in mind. And we'll talk next about beta blockers. This comes up all the time on the consult service. So if somebody is on a beta blocker and you're sending them to surgery, you should write in your note, continue the beta blocker. That's a class 1 indication. So we don't stop beta blockers, we continue them. If somebody was not on a beta blocker and you think they should be, don't start it within 24 hours of surgery because from the POISE trial, we learned that that's bad. So if you're going to start a beta blocker, you have to put them on it like a week before, not the day before. So generally, if they're on it, I leave them on it. If they're not on it, don't start it. Statins class 1 should stay, and all the rest, it follows. Pardon me, sorry. So this is about the coronary stent. So if they're within, 30 days of a bare metal stent, don't go to surgery. You don't want to stop the clopidogrel. If they're within 365 days of a drug-eluting stent, don't stop the clopidogrel for elective surgery. However, you could proceed after 180 days sometimes, if there's compelling reasons. We could talk about that. All right, let's move on to some of the clinical guidelines and where they come from. So this is the RCRI, or Revised Cardiac Risk Index, from Tom Lee and colleagues. And everybody knows this one. It's 6 things here. Pardon me, I'm sorry, I'm losing my voice. But there's all the different types of surgery, intrathoracic, intraperitoneal, or suprainguinal vascular surgery, which this lady was not having suprainguinal technically. They mean more like the aorta. But history of ischemic heart disease, history of heart failure, insulin, which this lady was on, serum creatinine above 2, history of. So this lady has a high RCRI, as you can see. Now, the surgeons have their own index from this NSQIP, NSQIP, and you can go on your phone and calculate all this based on the surgical data. This is a large database, very useful. I'm not going to go over it anymore. There's a Gupta risk index, a MICA score, MICA score, that Dr. Gupta came up with, also valid. This is their MICA score. Again, I'm not going to go in detail. this is newer information. The Canadian Cardiovascular Society guidelines on perioperative cardiac risk assessment, they came up with, and again, I don't have enough time to do in detail, but they're the ones that came up with the idea of using brain natriuretic peptide. So if your BNP is, let's say, below 300, then you're in good shape and just go ahead to surgery if your BNP is above 300. So how do you decide when to check a BNP? There's all clinical predictors that you have to put in there. We don't commonly use this right now in the United States, but it is used worldwide. And in some of your calculators, if you go into the RCRI score, it'll tell you at the bottom of the page, consider checking a BNP. That's where that comes from. So we can talk about it more if you have questions, but just wanted you to see it. And this is the last and newest one from 2019. This is called the CVRI, or CV Risk Index. It comes actually from Beirut, Lebanon, American University of Beirut. And they looked at over 3,000 patients. The RCRI was based in about 1,500 patients. This is double that. And they found the following 6 major risk indicators. If you're over age 75, this is off to the right of the slide. Over 75, history of heart disease, symptoms of angina or dyspnea, hemoglobin under 12, any kind of vascular surgery or any emergency surgery, you get a point for each of those. Low risk is 0 to 1 points, intermediate 2 to 3, high risk greater than 3. So this is the newest index, which the United States has not yet bought into. So coming down to the home stretch, what do we do in the U.S.? Well, we don't follow all of those guidelines per se. I just wanted you to be aware of them. This is what we risk stratify. So the first thing is you assess for RCRI or an SQIP or one of those, and if they're if they're under 1%, they're low risk. Just go to the OR. If they're above 1%, they have elevated risk. Then you assess your functional capacity, which we tried to do in this case. If they can walk 2 blocks at a normal pace or climb a flight of stairs, that's 4 METs, then they go to the OR. If they can't do that or you don't know, that's where you consider the stress test, which was done in this case. And then you manage based on that. Or you tell the surgeons do a different surgery. You know, sometimes they were going to do a larger operation. Maybe they can get by with a smaller operation. So once you do the pharmacologic stress test, if it's normal, you go to the OR. If it's abnormal, so in our case, it was considered normal, but it's abnormal, then you modify their surgery risk. You can't change their surgery risk. You can tell them they're high risk and consider a beta blocker, again, as I told you, not the night before, or perform coronary revascularization. So these are the U.S. Guidelines. Let me summarize that. It's basically everything that was done in this case. You look at their underlying risk factors. This lady had a high RCRI above 3, so that puts them in the higher risk group. You assess their functional capacity. Can you do 4 METs or not? She couldn't. Then you consider pharmacologic nuclear test, or you don't do the test if you think that you're not going to be able to follow through on the results. So it's going to come out abnormal and you're going to do the same thing, then don't do it. But if you're going to act on it and it's abnormal, then you revascularize according to guidelines. Sorry, there's some background noise outside.
Let me just remind people that are not presenting, please, somebody out there is, I don't know, baking a cake or something. I don't know.
Yeah. So at any rate, that's really a quick overview of all of the literature that went into this. But our 2014 guidelines still withstand, which is basically what was done in this case. I think the U.S. is due for new guidelines shortly. I don't know if anybody has insight on that, but I suspect we're going to have an update, and they're going to put the Canadian and probably the Beirut data will have some bearing on the newer guidelines, I suspect. So let me stop at this point, see if there's any questions.
That was a great summary, Perry. Thank you. Anybody have questions? I have 2 comments. One is that the American Society of Nuclear Cardiology also has guidelines as to when, or the appropriateness guidelines as to when nuclear stress testing is appropriate before stress testing. It doesn't really go into all the details about risk stratification, but it does indicate when they think that preoperative nuclear stress testing is appropriate. The second thing I'd like to emphasize is that once you're asked to be a consultant and assess risk, then I consider myself part of the team to determine whether the surgery that's recommended for the person is appropriate. So it's not, you're not just rubber stamping, go ahead and do it or can't do it. In many cases, in my patients as an outpatient, you can actually either postpone surgery or elective surgeries until patients are on better medical therapies. You can change the therapies. You know, many people who come for elective joint replacements, who I think are relatively high risk, we can actually change to other methods for trying to treat their orthopedic problems. Or you can discuss with the patient and discuss the risk with the patient, and the patient often then decides not to assume the risk of surgery. It's not left up to the surgeon or the anesthesiologist necessarily, but as long as the patient understands the risk, then the patient can decide whether or not to continue down the road of having elective surgery. So, you know, I would say don't just necessarily be passive about it, that you can become an active member of this preoperative decision-making team.
I would want to add to that. I agree with you 100%. I think that anytime you enter into the care of a patient and you make a recommendation or whatever, then you have an obligation to talk to the patient about it, let them know, but also to follow up on that. So, for example, if you say somebody's higher risk, but you think surgery should go forward, but I think they're a higher risk patient, then you can recommend cardiac monitoring after the procedure, get an EKG after the procedure. If you look back, I think I just want to, on this risk assessment, it tells you measure troponin daily for 48 on the bottom there, 48 to 72 hours, obtain an ECG. In other words, if somebody's high risk, you don't just walk away and say, well, you're high risk, sorry. You can actually follow that person and try to modify their risk by staying ahead of the curve, by checking their EKGs each day, seeing if they're getting into trouble. So that's a big part of it. And I think you're right, Rick. Sometimes we just write our note and walk away, and there's more to it.
Yeah, I agree with you. Mm-hmm. Perioperative management in the high-risk patient is really important.
And I have one quick last slide, which is that one.
Yeah, good morning. It's Johnny.
The new little baby in the middle. Okay. Go ahead.
Yeah, hi, it's Jose Trani. How are you guys doing this morning?
Good, Jose. Good morning. Thanks for joining.
Sure. I have a couple of points. Number one, I totally agree that from a surgical standpoint, when we're asking cardiology to get involved, that it's not just checking another box to get the patient to the operating room and making sure anesthesia is satisfied. We're certainly looking to cardiology for recommendations, and not just to stratify them, but also certainly if there's anything that we can do intraoperatively to make this patient safer. A lot of times there are different things that we can do with regards to anesthesia risk profile as well. So, for example, for an AV fistula, most of them are done with MAC and local. Not that many of them undergo general anesthesia with the additional risk of hypotension during induction. And so certainly, the more information we get from you guys, hopefully the safer the patient experiences in the operating room. One question I do have is, a lot of my partners think that post-operative EKGs plus minus troponins are ordering them routinely. I just wanted to know if anyone thought there was any benefit from that management strategy, or which patients would benefit from that.
I personally don't like the automatic troponins. I don't recommend that, because that's opening up a whole can of worms. But I think getting an ECG on a high risk patient is a low risk thing to do. You can look at the ECG just to make sure that you're not seeing anything obvious. But to do troponins on everybody, you're going to find so many abnormalities that you don't know what to do with. I agree with you. I don't think that's necessary.
Yeah, that was certainly my thought as well. But when you're looking at literature, especially like RCRI, I mean, that's part of how they identified patients with cardiac changes, right? Everyone routinely got post-operative troponins, and we had a long discussion when I was in residency about this. I just wanted to see if people had different thoughts, or if that management has changed. But I certainly agree with you guys about the lack of necessity for that.
I think a lot, I was lecturing yesterday on our rounds, a lot is clinical judgment. You have to, what you're doing should match what's going on with the patient. If the patient's doing well, but their troponin is, 2 points above normal, I'm not sure that's meaningful. I think if the patient's not doing well and they're in, a shock-like state, yeah, you'd like to know those things. So you have to individualize. I don't think there's any statement that works for all here. But in general, to check routine labs for MI, probably not a good idea for most of our patients. But in a high-risk patient, keeping them, for example, in a cardiac monitor could make a difference. So sometimes I'll talk to the surgeons about could they be monitored post-operatively, maybe for a day or two, because I'm really worried. And I think that is prudent. So sometimes this RCRI, and even these other things are being, there's newer ones. That's why I showed you today. RCRI is old now. There's newer clinical predictors that look at different things. BNP is big in the Canadian literature, which we don't use in the US. At least I haven't seen it used for risk. And I think that might be interesting moving forward. And there's recommendations in the Canadian literature to check an ECG for 3 days post-op. Because the peak incidence of heart attack after surgery is not the first 24 hours. It's usually the second 24 hours, day 2 or 3, because catecholamines are revved up and high. The person's coming out of anesthesia. They're more aware of pain on the second day. So sometimes you have to watch a couple days. Anyway, I'm taking too much of your time, but those are my comments.